Well, hello, you wonderful radiology geeks, and welcome back to the fourth installment in our lecture series on normal radiographic anatomy, where we will be going through the foot and ankle today. So, there are quite a few standard projections used in the analysis of the foot and ankle. There's the dorsiplantar, there's dorsiplantar oblique, there's the lateral foot, there's also the toes, and they can be taken as dorsiplantar or lateral. So obviously that's mainly of the foot itself, and then of course you've got the ankle projections, which are the mortis view. Then you've got the lateral ankle, then the obliques, where you can have internal or external rotation effectively, and then there's the axial calcaneum projection, which we're not going to go through today because it's not exactly the most commonly used projection anymore, but it is available to you, and obviously if you look it up in your textbooks you will come across this view. With the particular X-ray equipment that we have in our facility, this particular projection is not the easiest projection in the world to achieve, so that's one of the reasons why we're not going to go through it today. So dorsiplantar, which is there's a standard view best for analysing the overall anatomy, including the tarsals, the metatarsals, and the phalanges, because of the overlying anatomy of the tib and fib. Sometimes the talus and the sort of main body of the calcaneum can't really be evaluated correctly on this particular projection, and you'll see what I mean in a moment when you see the view itself. But it's great for obviously overall assessment of the foot and ankle, with obviously Lisfranc's fractures, dislocations being the main reason why you would obtain this view, and then the other ones, the dorsiplantar oblique is much better for evaluation of the Lisfranc's fracture dislocations of the tarsals, metatarsals. So when this is how you set the patient up, the central ray is at the base of the second metatarsal. So somewhere around here is going to be your midpoint, or your central ray, running up the second metatarsal. And as you can see, with the overlying anatomy of the ankle, this is going to obscure your view of the main body of the calcaneus just here, and obviously the body of the talus is also going to be difficult for you to evaluate with this particular projection. However, you can still see the navicular, you can still see the anterior aspect of the talus, and you may also be able to see the anterior aspect of the calcaneus. So if I show you what I mean, so here is obviously the tib and fib, here's the medial malleolus. So you can just about make out the distal aspect of the tibia just here, and then you've got the fibula just here, making up the medial and lateral malleoli. Here is the talus just here, and then you also have, so this is also talus all the way here, this is also calcaneus just here, then you've got the navicular. So you can see some aspects of the if you get the exposure level right, you can see these areas of the tarsal bones. However, as I say, sort of full body analysis of the calcaneus is not easily achieved with this, which is where the axial calcaneum view comes into its own as a really good way of evaluating that area of the calcaneus as a dorsiplantar sort of projection. So obviously, just to break the anatomy down, here are the tarsals, then we've got the metatarsals, and then of course we've got the phalanges at the end. Just to go through the finer points of the anatomy, there are 19 areas that we're going to go through right now. So number one is the medial malleolus, down here on the distal aspects of the tibia. Then you've got the lateral malleolus, which is obviously the distal aspects of the fibula just there. Then we've got the head of the talus. Then we've got aspects of the calcaneus that we can in fact see. Then we've got the navicular. Then we've got the cuboid on the lateral aspect of the midfoot just here. This is the tubercle of the fifth metatarsal. Very important area of anatomy for evaluation. Any of you brand new students that are just getting into your radiographic anatomy lectures and understanding of this field, this is a very, very important aspect of radiographic anatomy for you guys to understand. For the foot, it is better seen on the medial oblique view, which we're going to go through in a second as well. And then from working from lateral to medial, number 8 is the third cuneiform. Then you've got the second cuneiform, and then number 10 is the first cuneiform and the medial aspect of the foot. Number 11 is the medial sesamoid bone of the big toe. And number 12 is the lateral sesamoid bone. Number 13 is the shaft of the second metatarsal. So obviously, just to highlight, all of the shafts of the metatarsals are these bits along here. Number 14 is where the neck of the metatarsals are, and then 15 is the head of the metatarsals. Number 16 is the tarsal phalangeal joints, the metatarsal phalangeal joints along here, effectively the knuckles of the foot. 17 is the proximal phalanx. Number 18 is the middle phalanx, and number 19 is the distal phalanx. And with the thumb in the hand that only has 2 phalanx, you've got proximal and distal phalanxes on the thumb. Is the same for your big toe, whereas all the other fingers obviously have 3 phalanges, and so do the toes. They have the proximal, middle, and then distal. The big toe only has the proximal and distal. So the lateral projection, again, great for viewing overall anatomy, especially true for, again, Lisfranc's injuries, fracture dislocations of the tarsals and metatarsals. This view can be taken standing or in a seated position. It depends on the ambulatory status of the patient. So if the patient has a significant foot or ankle injury and cannot stand, then you'll obviously take it non-weight bearing, so you'll have them sitting or laying down. Whereas if you're looking for more of a degenerative process and the patient is ambulatory, we're not taking the projections as a result of trauma series, then you can have the patient standing for these projections as well. And the central ray is over the tubercle of the 5th metatarsal. So here is how you would obtain the projection. You can go a little bit more superior up the distal aspects of the leg. However, to really clear up the image, trying to get just simply the foot and ankle in the evaluation is going to give you a better projection overall. You'll have less scatter and things like this. However, you'll find some clinicians will go all the way up to all the way up past the metatarsals, all the way up to roughly the sock line, just there. So here is the basic overall projection, and it gives you a great view of the main body of the calcaneus, which is obviously missed on the dorsiplantar projection. The axial calcaneum view, just to sort of really hammer this home, that's taken from it's again dorsiplantar, but it's got an oblique projection that comes all the way through from about where the Achilles tendon will attach onto the calcaneus, and it allows you to evaluate the main body of the calcaneus through a dorsiplantar projection. The anterior aspect of the calcaneus you can see on the standard dorsiplantar projection is just here, and then we've got the head of the navicular just here. This is obviously the body with the dome of the navicular just here, and then you've got the talus, the head of the talus, dome of the talus just here. Here's the navicular. Sorry guys, I'm getting ahead of myself just there. So there's the calcaneus for you, and then you've got the head of the talus, just so that I can prove that I actually do know my anatomy. There is the talus just there. Then we've got the navicular. Then we've got the cuneiforms and the cuboid, which are all obviously superimposed on top of each other in this projection. So you're not really going to be able to isolate which bone is which, unless you have a substantial dislocation of one of those bones, at which point you may well be able to identify it through its shape. And then of course we got the metatarsals and then the phalanges at the end. So getting into it now, we've already made a mistake in what I'm talking about, so you know that we're on the ball. So the medial oblique projection. This is obtained with the ankle in an everted position, usually supported by a triangular block or wedge of foam to help support the patient's ankle in this position. It's not the easiest position for some people to get into, especially when they've had a trauma and they've got lots of swelling around the ankle, so it's not always the easiest projection to do. Again, great for assessing overall anatomy, and it really brings both the cuboid bone but also the tubercle of the fifth metatarsal, really brings it into profile, so it's really good for evaluating these two structures just here. Also, again, with the Lisfranc's lines and things like this, when you're trying to evaluate somebody for fracture dislocations, it is very helpful to get a really good quality medial oblique projection. Okay, so central ray is over the navicular and the cuneiform region. So here we are. This is a triangular foam block, and it's everting the ankle medially over this way, so it's going to bring the tubercle of the fifth metatarsal into a much better alignment, and so will the cuboid, which is going to be somewhere around here. So the navicular will be somewhere around here as well. And here we are. So now you can really see what I mean. When you're drawing your Lisfranc's lines, you can really draw the lines along the tarsal metatarsal joints along here. It's a lot easier to do with the medial oblique. It really brings obviously the tubercle of the fifth metatarsal into alignment, and then you can really appreciate the shape of the cuboid just here as well, and you can see through the joint lines a lot better. So it is a really helpful view in order to evaluate these two structures in a much better way. Like I said, the only difficulty with this is usually if the patient has significant trauma, and so they have quite a lot of pain and swelling, so it can be difficult for the patient to get into this position and stay there as well. And there we are, just to prove that I do know my anatomy. And there's your labels that I completely forget about, which is why I'm shocked when they turn up on the screen. So the Mortis projection, sorry, I'm just enjoying a bit of coffee. The Mortis projection, best projection for examining the dome of the talus and of course the ankle joint with the the malleoli, both medial and lateral, are present on this projection. The patient is positioned with their ankle in a dorsiflexed position. Can be taken with an eversion or inversion positions to stress the ankle, an assessment of stability and ligamentous integrity. So if you've got a patient who has had a significant injury to the ankle, whether it's an inversion or eversion injury, you can take this projection with them non-weight bearing, and then you can basically stress the ankle into whichever direction the injury occurred, and it allows you to evaluate the ligamentous integrity. So if you see any widening of the joint spaces or anything like this, or any excessive motion occurring of the talus in particular, or a separation of the distal tib and fib, then you know that there's going to be ligamentous injury to the area. So this can be quite a handy view for stressing the patient's ankle after an injury as well. The central ray is basically midpoint between the two malleoli, just here. So here we obviously have the lateral malleoli and the medial malleoli, and you want to pick the midpoint right between the two, and you should hopefully end up with something that looks like this. So you will see a lot more of the distal aspect of the tib and fib. You'll also see the syndesmosis between the distal tib and fib just here, and the obviously this is obviously the location of the interosseous membrane that you're not going to see on an X-ray. But here's the dome of the talus. Here's the medial malleoli, here's the lateral malleoli, and you've got the lovely joint spaces between all three areas. Okay, so obviously the evaluation of both the dome of the talus. What you're looking at just here as well, just because this always confuses people, what you're looking at just here is not a completely flat surface. The dome of the talus, because the ankle this is better seen on the lateral ankle projection I'm going to go through with you in a second, but you're looking at a domed surface. So when you see almost like the horizon of a domed surface will look flat, but it obviously isn't. It's curving away from you when you're looking at it. So it's a bit of an optical illusion with this. So once you get your head around that, if you see some of the defects that can occur following trauma, so anything that interrupts the bone integrity of the talus, then it's really helpful to be able to see it. And then if you've got those complications from injury, which we're not going to go through, because I'm trying my best to not go through the pathology, because that is not what we're trying to do. This is normal radiographic anatomy, so I'm doing my best to not give the game away. There we go, just so that again I can prove I know my anatomy. There we go. So here it is on an MRI scan. So here's the dome of the talus, here is the medial malleolus, here is obviously the distal tibia. The fibula is not present in this particular projection, so the lateral malleolus is not present. That is because of obviously the positioning of the two bony structures themselves. They are not necessarily directly in a sort of coronal plane. They are not directly opposite each other, so you will not necessarily see them together on an MRI. But here they are on a CT scan. You can see what I mean, where we have the dome of the talus and lovely joint spaces, medial malleolus just here, lateral malleolus, but what we've only got is the lateral malleolus. We don't have the rest of the fibula, whereas here we've got a nice shot through the mid aspect of the tibia. So the fibula and tibia are not going to be directly aligned with each other, so when you're taking some of these advanced images, some of the anatomy will be missed. But on an X-ray, because it's a two-dimensional deconstruction of, or a two-dimensional projection of the three-dimensional object being the patient, and you get all of the anatomy in there, they get superimposed on top of each other, and so they look as though they are directly in line with each other in a coronal view, but they're not. Okay, so it's a bit of a visual illusion that you'll get with an X-ray. Here's the stress X-ray that I was telling you about, where you can take the ankle into eversion, and here you have a nice widening of the joint space between the dome of the talus and the medial malleoli, and here we actually have a fracture through we have an oblique fracture through the fibula. So that's allowing this translation to occur just here. But here's an example of that stress film I was telling you about, where this is going to be the evaluating person's hand, and you stress the ankle into the direction where you want it to go, and that may reveal more details about what the injury has occurred, and of course allows you to assess ligamentous integrity. So to get widening of a joint space, you will have to have ligamentous disruption and ligamentous instability. So here we are on an X-ray, so you can diagnose that type of injury using the X-ray. So the lateral ankle, it's really easy to achieve this particular projection in any type of trauma cases. The patient is going to be non-weight bearing. You can take it weight bearing, obviously, but it's one of those things that can be very difficult to do. So, but in terms of a really quick and easy way to evaluate the bony aspects of the ankle itself, it is a really easy way to assess it. It's great for reviewing the dome of the anatomy and what is commonly known as the posterior malleolus, which is on the distal aspect of the tibia, obviously the posterior aspect behind the talus. So there is a posterior malleolus, and you can have a trimalleolar fracture, where you have a fracture of the medial, lateral and posterior malleoli all at the same time. So that's going to be something you'll go through the trauma series. Central ray is the medial malleoli. And here we are. So we have distal tib and fib superimposed on top of one another. You can just about make out the lateral malleolus just there superimposed on everything else. And here is the domed aspect of the talus, the body of the talus just here. So you can really appreciate the shape of the dome. So when you're looking at it through basically an A to P projection just here with the mortis view, you'll see as the central beam hits here, this will therefore appear flat, so it looks like a box, but it isn't. Obviously, it's a domed or curved top that you're looking at. So as almost the horizon of the highest point of the dome is observed, it will appear flat from the front, but obviously, like I say, it isn't. It's curving away from you just here. But again, great way for evaluation of the main body of the calcaneus as well, and the head of the talus also comes into a really nice projection as well. Here it is on an MRI. Again, you can see the cartilaginous surface is just here as well, which is very, very helpful, very, very nice to see. And of course the trabecular pattern of the bone is also very present as well, which is lovely. It's always good to see that kind of thing on these projections. This is the calcaneal fat pad under here, which obviously you can tell is obviously mainly made up of fat. In here you can see just how thick the calcaneal fat pad is, whereas obviously that's always quite a shock to a lot of students, just how thick this can be in people. So when you feel as though when you're poking around the skin of the underside of your foot, just here, you feel as though you're directly onto the bone, but there's quite a lot of mass between you and the actual calcaneus itself, which is always really interesting for people to observe. And this is a T1 weighted MRI. So this is T1, where the fat signal is really high. So obviously bone marrow, and obviously the fat signal through the calcaneal fat pad is very bright. So you get a high signal return from a T1, whereas on a T2 will suppress the fat, but you'll be able to see the water. So the synovial fluid within the joint margins shows up really nicely. So again, it's a great way for evaluation of obviously especially bone edema following a trauma. And here it is on a CT scan as well. So again, the great thing about CT scan is the trabecular evaluation is absolutely fantastic to see the trabecular pattern within these structures. And of course, anyone who's got more advanced training and has gone through trauma series and pathology will understand the importance of being able to see the trabecular pattern. Here we have a normal radiographic appearance of a pediatric ankle. I just wanted to show you guys the epiphyseal growth centers and the epiphysis and the growth centers of the distal tib and fib, and the gradual formation of the tarsal bones down here as well, and obviously the gaps between them. Pediatric trauma is an absolute art of radiology to be able to evaluate them correctly, because it all looks like it's broken, it all looks like it's fractured, and it looks like a complete mess to the complete novice and the beginner. So but getting into peds, and especially pediatric trauma, is a real art form of radiology, and I appreciate anyone who's gone through that training, how difficult it can be to achieve what you're after, basically. So the last few projections will include phalanx projections, where they're typically done in the cases of trauma and serious pathology cases. However, there's debate over whether or not they're actually particularly helpful in trauma cases, because if you fractured a toe, it's got to be a horrific fracture for you to receive any treatment in these cases. If it's just a you stubbed your toe on the coffee table and you feel as though you fractured your toe, there's not much anyone can really do about that. It will heal itself gradually over time. So there is questions about whether or not these are still standard projections or whether these are specialists, but either way, we're going to go through them now. The central ray is basically over the metatarsal phalangeal joints of whichever toe is being evaluated. You can evaluate them in a dorsiplantar, or you can do it in an oblique, or even in a lateral projection as well. But again, it depends on the mobility of the patient, because if you've got a patient who's had trauma and is in a lot of pain, then it can be quite difficult to obtain some of these projections. But at least you're getting your 90 degrees, you're getting your dorsiplantar, and then your lateral, you should be golden to be able to assess any type of fractures at all. So obviously you can take them as a group, where you can see all and evaluate all of the metatarsals and the phalangeal bones all together. Very, very helpful way of doing this. As you can see on here as well, this little toe only has proximal and distal phalanxes as well. It doesn't, so it's the same as the big toe, whereas it's the middle three. Some people do still have three phalanxes on the little toe. It depends on the normal radiographic appearance of those patients. So some people will, but some people won't. The big toe is a standard where you've only got the two. But yes, so this is where you can obviously evaluate all of the toes as a group, or you can try and shut them down and try and take them as individual projections, you will always get other toes involved. You will never be able to separate the toes out far enough to evaluate them in isolation. However, this is obviously the big toe being evaluated and more of a lateral projection just there as well. So you basically, central ray is metatarsal phalangeal joint of whichever toe is being evaluated. This is a sesamoid view. This is very reminiscent of the carpal tunnel projection that you can get in the wrist as well. Sesamoid bones of the big toe can be fractured, and they can be involved in that kind of thing. So getting this view, basically you're asking the patient to bend the toes up as far as they can, and you shoot through what can effectively be described as the tarsal tunnel, basically, and here you'll see the sesamoid bones in profile a lot better. So for evaluation of fractures, it can be very, very helpful for patients that have had trauma and they have residual pain that may have been missed on the standard projections from your standard trauma series. So thank you very much for your attention today, guys. That is the main x-rays being obtained for the foot and ankle evaluation. The next in our series will be the knee, so we're going to work our way up the body from now. So we're going to go, we'll go lower limb up into the hip and pelvis, and then we'll work our way up the spine from there. Okay, so you know, if you enjoyed today's lecture or any of the lectures in this series, if you could like and subscribe to the channel, that'd be absolutely amazing. Let YouTube know that you like what you see. You can now also support us through Patreon as well. So any help in that sense to keep the channel going will be very, 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 very much appreciated. Otherwise, I will look forward to seeing you in the next one. Take care, guys. Speak to you soon.